Good afternoon, everybody. Welcome to the IPHAM seminar series. We're happy to get it started again, and very glad that all of you could join this afternoon. I am delighted to introduce to you Dr. Jaline Gerardin, who's Assistant Professor of Preventive Medicine at the Feinberg School of Medicine, and also of Industrial Engineering and Management Sciences in the McCormick School of Engineering. She's a member of the Institute for Public Health and Medicine, the Institute for Global Health, and the Northwestern Institute on Complex Systems. Dr. Gerardin is an international expert in infectious disease modeling and in measuring and predicting effects of policies and programs for infectious disease containment. Her work has contributed to defining stratification metrics for intervention deployment and understanding the intervention mixes needed for effective malaria control and elimination across diverse endemic settings globally. Earlier this year, Jaline directed her expertise towards developing policy-relevant models to predict the magnitude and distribution of the COVID-19 pandemic, as well as effects of public health approaches to combat spread of the virus. Please join me in welcoming Dr. Gerardin, who will be speaking to us today on the topic of modeling COVID-19 transmission and containment in Illinois. Jaline, the floor is yours.
Thanks, Ron, for the introduction and for inviting me to talk about some of the work that I and my group have been doing over the last few weeks. So as Ron mentioned, we are a group that does malaria modeling, specifically to inform malaria policy in malaria endemic countries. So it's a lot of the same kind of mental frameworks around policy and modeling and the role of modeling to inform policy, but obviously applied on a different disease and in a very different setting. So I have certainly learned a lot over the last, however long it's been, 7 weeks or so that I've been working on COVID and working with more of my colleagues here at Northwestern and in Illinois on this. So I want to start off by I think I'm in Zoom instead of PowerPoint. I think this is a rookie error. Oh, there we go. Showing just what things have been looking like in Illinois over the past couple of months. This is public data that's been posted by IDPH, Illinois Department of Public Health, on their website. So we're seeing here reported cases, so people who have tested positive for COVID-19, and deaths, so people whose death have been attributed to COVID-19. So these are cumulative cases and deaths that we've seen over the last couple of months. And we've, as of, I think a couple of days ago, we had nearly 3,000 reported COVID-19 deaths. So quite a hefty burden of COVID. When we look more closely at the daily numbers, so this is daily incident cases and daily deaths, again, from their public website, we can start to try to assess whether things are getting better. And it's not very obvious just from, looking at this by eye that things are getting better, but we can take a closer look later. One of the frustrating things about COVID, especially in the United States, is being able to interpret the blue line here. So as we know, the availability of testing has changed so much, and the requirements for getting a test have also changed so much since late February to now. So initially, it was quite hard to get a test, and you could only get tested if you were symptomatic and had a travel history to a country with known COVID outbreak. And then tests became far more widely available. At Northwestern, we instituted a drive-through testing, but then after that, people started running out of swabs because the swabs were being made in northern Italy, which was dealing with an incredible COVID outbreak there. And so then requirements for getting tested started narrowing again. And then I think since that, testing has now become more available. So the state is able to test over 10,000 people per day right now, and they're aiming for to ramp that up to more tens of thousands and hopefully 100,000 per day. But all that together makes it rather difficult for us to interpret this blue line. just what does a certain number of reported COVID-19 cases really mean? And so a lot of the modeling that's been done in Illinois, not just by my group, but by other groups, has really focused on looking at the deaths numbers. And there are clearly far fewer deaths than cases. And so this starts to present a challenge when we want to look at Illinois, not just at a state level, but at a sub-state level. And that some areas have been lucky to not have so many deaths, but that also means that the models that we build of transmission in those states are far less certain, just because there's not as much data. So hopefully we will one day in our journey in COVID have plentiful testing, have a consistent case definition, and so we'll be able to understand much more rigorously what is going on in areas with less transmission. But for now, most of our work is focusing on looking at those deaths numbers as well as some hospitalization numbers. So I mentioned that we are considering things at a sub-state level. I just want to show you here a couple of maps. This is reported cases. So again, a number that is not very easy to understand. So cumulative number of positive COVID tests that have been found in each county of Illinois. And the gray counties are counties where no one has been found positive as of my data poll from a couple of days ago. And we can see on the left side that the vast majority of positives are coming from Cook County. I think we knew that. And then also the surrounding counties have also had a bit more of the burden. But once you normalize by population, which is what's on the right-hand side, we start to see some counties pop up a little bit more as hotspots. We can see the East St. Louis area in the Southwest region. We can see Jasper County kind of in that Southeast region. We can also look basically at the same kind of maps, but looking at deaths instead of cases. Again, most of the vast majority of deaths are happening in Cook County and the surrounding counties. But once we normalize by population, we start to again see some counties that are popping up as areas that probably need some special attention. So that red county in the southeast area, that's Jasper County. They had a pretty bad outbreak in a long-term care facility. I think maybe all of their deaths have happened in a long-term care facility. So as we hear more about these kind of vulnerable populations, so these nursing homes, prisons, the meat processing plants, it's also important to understand just what is going on within each county. All right, so you may have heard at the press conference a couple of days ago, Governor Pritzker announced a plan for Illinois to reopen and kind of stop these stay-at-home policies that we've been living with for the last month and a half or so. So a big question from us and also from the governor's office and IDPH is, how can we do this safely? How can we balance our economic needs with our public health needs? So on my side, what I'm thinking about are questions like, when can we open different parts of the state, given that different parts of the state are not the same? So we know Cook County, for example, is much more highly populated. It's denser. People tend to have more contacts than people who live in more rural counties. Does that mean that people who live in those less contact-intensive counties might be able to reopen sooner and to a greater degree than people in Cook County? In places that have reopened, given that we're no longer doing as intensive social distancing interventions, what other interventions should we be implementing there? Because we know that in the absence of any intervention, we expect to see an increase in cases, right? Because that was what was happening all the way through the middle to end of March. So if we're now relaxing these social distancing interventions, what other interventions need to happen there, and to what kind of quality that will allow the places that have reopened to stay relatively low COVID or even COVID free. And then lastly, it's really important for us to be able to tell if things start going south in a particular area. So we want to know as soon as possible if infections are going up, so that we can then decide what to do. Maybe that's to increase the amount and quality of contact tracing. Maybe that's re-implementing social distancing and stay-at-home policies. But whatever it is that needs to happen, the sooner we know, the better. So what we're going to do is we're going to take a modeling approach to kind of game out different scenarios of what could happen in Illinois under various different reopening policies and different other intervention strategies. So let's take a quick walkthrough of kind of the modeling framework that we've built up. So this is a very basic SEIR modeling framework that probably you have heard a lot about in the news. It's kind of surreal to have so much modeling in the news, honestly. But what we're doing is a compartmental version of SEIR, which means that each one of these letters represents a bucket. And within each bucket, there are people. So we have a bunch of people who are in the susceptible bucket, to begin with, before COVID was introduced, and then we'll introduce some COVID, and then some people will become exposed, which means that they have COVID and they're kind of progressing along the course of disease, but they're not yet infectious. And then after a while of being exposed, so about 5 days or so, they become infectious, and then eventually they may recover. And we're assuming here that once people who have experienced COVID recover from COVID, that they're no longer susceptible. So we're assuming a permanent sterilizing immunity. And that's something that is being actively worked on right now. To what extent is that a good assumption? But for the purposes that we're looking at, which is looking at COVID dynamics through the next few months, I think there's no reason to believe that people who've had COVID will once again become susceptible to COVID within the frame of a few months. So we're just going to go with this. For now, it makes our lives a bit easier. And hopefully it's a reasonable assumption, but we can always adjust this as people learn more about the disease. So this is the basic framework of an SEIR model. And for COVID, what we want to do is we want to expand that gray box, so the infectious box, to capture certain features of the disease. So here we've expanded the gray box to include asymptomatic, so AS, infections, because we know those happen. We have pre-symptomatic, so people who will eventually become symptomatic, but they're not quite yet. We know that lasts for about 2 to 3 days. And then once they become symptomatic, we have people who have mild symptoms and we have people who have severe symptoms. So the way that people move through this progression of disease and what fraction of people go where and how long they stay in the bins, that's all information that we can glean from the literature largely. So people who have studied COVID in other settings have done a lot of work to measure things like incubation period and fraction asymptomatic and fraction severe and recovery time. And we're using numbers that other people have gathered to parameterize these arrows. Then we can take another step of complicating our model, which is to think about in a little bit more detail about what happens to you when you have a severe disease. So for example, you could reach the hospital. You could become admitted to an inpatient facility. You could, if your COVID is really bad, make it to the ICU. You might become vented, and if your COVID is terrible, you could die instead of recover. So by putting in these compartments into our model, then we can explicitly predict the number of people who are occupying inpatient beds and occupying ICU beds and needing vents. And in that way, we can then predict the capacity needs at different levels. So whether it's a state level or a sub-state level or even at a hospital level, this kind of framework allows us to make those predictions. And so I also, over here, have drawn my infectious gray box to not include people who are hospitalized or critical, because I'm assuming that once you've reached the hospital, you're being protected from transmission. So you've got enough going on around you that you're not transmitting to other people. So that is one assumption that this model can be making, and we can relax that assumption as well. And then I'm just going to present one more complicated version of the model. So this is the current version of the model that I'm going to show all our results for right now. We're using this version of the model. So here, the difference between this one and the previous one is that we're now also accounting for detected versus undetected infections. So as I mentioned earlier, we know that not all infections are detected, particularly if they're asymptomatic or mild. Hopefully more of those severe infections are detected. And so when we want to compare our model results to data, we do want to, is someone texting me? Oh, sorry. Is this an agent-based model? I think I will just, no, it's not an agent-based model, it's a compartmental model, but I think I will just go ahead and take questions all at the end. That way I won't get so distracted. And you can write, I think, Adela, you said that you were going to just collate all the questions as the Q&A person. So if people could send their questions to Adela, or if there's someone called Q&A, just direct all your questions there and she will triage. All right, so let's go back to this model. So basically, some of the people in the model are going to be more easily surveilled than others. So we're going to have people in these detected compartments kind of being found by the surveillance system, and people who are not in the detected compartments are more invisible. So how do we estimate how many people or what fraction of people are in those detected compartments? One of the methods that we use is a method proposed by Dan Weinberger, where he looks at excess unexplained pneumonia and influenza deaths and compares that to the number of COVID deaths to estimate the underreporting of deaths due to COVID. So a hypothesis is that all these extra PNI or pneumonia and influenza deaths could be due to COVID. If that's the case, what kind of underreporting do we think is going on? So we kind of think, based on this method that we've adapted from Dan to look just at Illinois data, we think that in the first half of March, very few COVID-19 deaths were actually being surveilled as COVID-19 deaths, and that's kind of been improving. His P&I data set only goes through the beginning of April, so that's why there's no more line after that. But we can complement this by applying a similar approach to other data sets, for example, data sets available from the CDC that report either other unflagged cause deaths or excess COVID-related deaths, to kind of get a general sense of how detection rates for severe COVID might have improved through time. So that's another way that we can get at some of these parameters compared to kind of just guessing, which is what we're doing for the fraction of symptomatic cases that have been detected. So then to kind of turn our attention to how we're applying this model to serve the needs of the state. So our state has over 100 counties that are divided into these 11 emergency management services regions. So that's EMS, and that's the scale at which I'm doing modeling. So I'll be saying EMS a lot through the rest of the presentation. And these 11 EMS are further grouped into 4 super regions. And this is the framework that the governor has announced for reopening. We're going to be thinking about reopening and progressing through phases of reopening at these super region levels. So we can see in the Northeast, that's the Chicago area and surrounding collar counties. And then we have the Northwest, the Central, and the Southern regions. So what we do is that we develop a model of COVID transmission for each of these EMS regions. And so what does it mean that a model is of a specific EMS region, given that most of our parameters are being collated from literature? So what that means is that for each EMS, we will be fitting 2 values to the model. One is the transmission rate, and the other one is the kind of date of importation of COVID into the region. So the transmission rate is describes how people move from the susceptible to the exposed compartment. And it depends on a few things. It depends on how many infectious people are also bouncing around in this area. And it depends on how likely you are to contact an infectious person, so a contact rate of people in the area. And also it depends on the kind of inherent transmissibility of the virus and how long infections last and things like that. So it's kind of a lot of different concepts rolled into one parameter, but we can conceptualize this at a little bit more simple level, just thinking mostly around contacts. So if I live in urban Cook County, which I do, and I take transit, which I used to do to go to work, I am contacting a lot of people on the Brown line every day as I'm squished in my car. But if I go to work by driving myself alone in my car, then I'm contacting many fewer people. And so we might expect that the transmission rate of COVID would be different in different parts of Illinois, simply based on how people live and interact with each other. So that's something that we want to make sure we capture in our model, because when we make statements around what strategies might be effective in different EMS, it's very important to have this transmission rate correct. So it describes kind of how hard your intervention has to work to contain the transmission of COVID. So higher transmission rate, you need to do more to contain COVID. Lower transmission rate, maybe you don't need to do quite as much. So how do we set this transmission rate? So we have data at the EMS level shared with us by IDPH. This data is just an illustrative example. This is not meant to be read into, this is just to show methodology. So the 3 data fields that we primarily look at for our fitting of transmission rate are first, the number of inpatient admissions of COVID positive people. In the middle, the daily census of people in the ICU, and then on the right-hand side, COVID deaths. So these are at the EMS level. And so what we then do is we look at these data points in a couple of different regimes. So in the blue regime, this is early in the outbreak, where there's less intervention and or interventions have not really had time to work yet. And so we use the early part of the outbreak and that slope to fit the initial transmission rate. And then we use the late part of the outbreak, or more recent period, to fit the transmission rate after stay-at-home policies have been implemented. So you can see that this curve is not just a linear increasing curve, is that it's been bent. That's great. That's the impact of everything that people have been doing to try to stop the spread of COVID. It's been very successful. So then what we do is that we want our model to be able to capture this general shape of the curve by fitting these basically a blue number and a green number, and then also the start date, which kind of adjusts how far to the left or right the red region is. So we do this for every EMS, and then we can simulate all the EMS together to look at what happens at the state of Illinois level. So just to give you kind of a general idea of the rates that we fit, I mentioned before that one might think that more urban areas would have higher transmission rate and more rural areas would have lower transmission rate. That's broadly what we see here in our left plot. We can see that Cook County has the highest fitted transmission rate, and some of the surrounding counties also very high. And then as we move to the downstate areas, we see some EMS with much lower initial transmission rates, though there's also a lot of variation there. And then after stay-at-home has been implemented, basically people are uniformly much lower. But there is actually still some signal in this stay-at-home rate. We might expect that different EMS might be complying differently with stay-at-home based on whatever people's needs are within the EMS. So one thing we've been doing is we're working with Beth Redbird, who has access to this really amazing SafeGraph data set. What I'm showing here is something that SafeGraph collects through cell phone data records. So this is looking at the fraction of people who have stayed home all day and how that has changed relative to a baseline week, which we've chosen to be in early February. So we can see there's this first period prior to about mid-March where we're kind of hovering around 0. So this is indicating that people are behaving just about the same way they did in early February. And then starting in mid-March, we see this big jump across all of the EMS. So that's people who are more likely to be staying home than they were in early February. So I'm showing you here every EMS because I think it's somewhat interesting that you can see different EMS are responding differently. EMS 11 has been the hardest core about staying at home. Some of the collar areas, so the surrounding areas of Chicago, the suburban areas, have been less apt to stay at home for whatever reason. And then the kind of more rural counties are falling in between. And here I just want to note that here are, for example, 3 major social interventions that we've implemented. On March 12th, the rule for no mass gatherings. On March, I think, somewhat 17th maybe, the closure of schools, and then March 21st, staying at home, and that's been continuing. I also want to note here that we can see kind of a general downward trend after kind of the peak in mid to late March. This would suggest that based on this data set that people are still very much staying at home more than they used to, but also not quite as much as they were in mid-March. So we might expect transmission to be picking up slightly relative to where things were in late March. It's hard to say. It's hard to interpret this SafeGraph data into something that's directly epidemiologically relevant, because here we're saying the relative change in the fraction of people who are staying at home all day. The people who are going out, we don't know if they are going out more safely, so if they're wearing masks, if they're going out by themselves, if they're not taking transit, or if they're going out kind of the way they would have normally prior to the COVID outbreak. So this is just something to kind of think about a general trend, and not something that we can directly plug numbers into our model. But it is interesting that, like, when we look at the EMS level, again, EMS 11, the Chicago area, huge increase in the fraction of people staying home all day. And then, as I said, the surrounding EMS from Chicago, a little bit less compliant, and then the more rural areas, kind of a mix. And when we compare that to what we fit to the actual data about on COVID cases, or severe cases and deaths, we see generally the same pattern in that that the kind of Northeast area is, especially Chicago, has reduced more their transmission rate, and then some of the rural, especially that central region, a little bit less. So this is just kind of an eyeball comparison to see how consistent data from cell data records and data from COVID are with each other. So what does the model then say? So here I'm going to present 2 scenarios, neither of which is realistic or what actually happened. So here I'm showing on the right-hand side what we think daily deaths are and will be if we implemented stay at home on March 21st and we just stayed at home forever and ever and ever. We think that the deaths would have peaked around early to mid-April. We think that EMS 11, so Chicago, would have had the most deaths, followed by the kind of Chicago surrounding areas, and then the more downstate EMS, which are kind of in that blue color, would have had far fewer deaths. And then just to note that this is our modeled number of true deaths and not just detected deaths. So I think peak daily deaths as reported by IDPH is maybe around 120 or 140. That's the most that's been observed per day, and our model is a little bit higher because we are accounting for some of those unreported COVID deaths. So that's staying at home forever. And then on the left side, I'm showing what our model predicts would have happened if we never done any mitigation whatsoever, just let the initial outbreak take its kind of natural course. And we can see that daily deaths would have been much, much, much larger, reaching over 5,000 over the whole state in around late April. We were seeing a lot more deaths as well in the downstate EMS. And just for a nice visual comparison, because these 2 y-axes are so different, this is what it looks like when you put them on the same scale. So what our model is predicting, based on what we think the transmission rate is in the absence of intervention and the transmission rate in the presence of intervention, is that our stay at home is working tremendously well. It's like really cut the head off that enormous death curve. And if we were to keep it around indefinitely, things would just get better and better in terms of lower and lower daily deaths. But that's not a particularly realistic thing to happen. So what we're going to do next is think about a hypothetical reopening scenario. This is not the actual plan that the governor and IDPH are coming up with because I don't know what that is. So I'm just playing with things in the framework of our model. And then when we find out what the plan is, so which region, super regions we want to reopen at what time, then we can apply the model to the actual plan. But for now, this is a fake plan. So in our fake plan, we are going to continue staying at home in that Northeast region, but we are going to reopen all of the other EMS regions, the Northwest, the Central, and the Southern. And our reopening schedule is going to look like this. So in mid-May, places that reopen are going to resume 30% of their initial contacts. And then in early June, they're going to go to another phase of reopening. So resuming 50% of their initial contacts, and then all the way until July, when they will have resumed 90% of their initial contacts, and we'll just keep that going after July. So I didn't go back up all the way to 100% because it is kind of probable that people will be a little bit more cautious, I think, with interpersonal interaction because we've had this experience of COVID. So maybe there are more people wearing masks, there are fewer handshakes, there's a little bit more caution around mixing. So we just go to 90%. These numbers are, completely made up. They don't correspond to anything in the Project Restore plan. I don't know what it means in terms of how people interact with each other, that 30% of initial contacts are resumed. This is just a number I can put into the model very easily. All right, so let's see what happens. So here I'm showing you the same two curves that we talked about before. This is over all of Illinois, two scenarios. In the red, no mitigation ever, peaking out at kind of 3 to 5 million infected people in early April. In blue, staying at home forever, so far fewer infected people, far fewer deaths. So the previous plot I had shown you of this had shown all the EMS stacked on top of each other, and that was our median simulation. And here I'm showing both the median in the line as well as the 95% observed interval once we start sampling uncertainty in parameter values. So here's our kind of two baseline scenarios. Again, no intervention ever and stay at home forever, neither particularly realistic. Let's try to hit it with our gradual reopening scenario where everywhere but the Northeast kind of starts to release beginning in mid-May and then being kind of more fully released by early July. So what do we expect to see? So basically we expect to see that in July and August and kind of starting to wrap up in September, another secondary peak happening in the state of Illinois. So we can then kind of look more closely, which EMS is it that these infections and deaths are happening in, probably going to be the non-Northeast regions. Yes, it's the non-Northeast regions. One thing to note is that in this particular instance of our model that we don't have the EMS kind of connected to each other. So we aren't modeling people moving between EMS. And that's something that we want to implement in the future. But for now, each EMS is kind of its own island. And we can see that reopening in EMS 1 through 6 as our kind of hypothetical scenario tried results in a lot more deaths happening in those EMS beginning in July and lasting kind of through September. So I mentioned before that that if we're lifting an intervention like stay at home, we might want to put in another intervention like contact tracing to prevent something like this. So what would happen if we then took this kind of gradual reopening context and then added contact tracing? So here again, same curve as before, now looking at all of Illinois so we can see that uncertainty range. So this is gradual reopening, no contact tracing. Now we're going to add in some contact tracing. The way we implement that is to increase the detection of mild and asymptomatic people and also have them quarantined. So reduce their infectiousness by somewhere between 70 to 100%. So once we implement that kind of contact tracing, we can see that first of all, the peak has shifted to a little bit later, and also it's quite a bit lower, maybe compared to the median of 1,500 daily deaths, we're now at maybe 1,000 daily deaths. It's also kind of dragging out that that epidemic a little bit more into October. But 1,000 daily deaths is still not that great. So we said, well, what if you did even better contact tracing? You could find, say, 80% of your mild and asymptomatic infections, and those people are going to quarantine with effectiveness of 70 to 100%. That's looking a lot better. Now we have basically kind of contained our deaths for the most part. There's still some uncertainty. So that purple band is the kind of light shaded region is reaching up past 500 or so. So it's possible that we could still have a pretty bad outbreak and quite a few deaths if things are not going well and our roll of the dice is unlucky. But for the most part, we kind of expect things to be mostly contained. And then we also ran a well, what if situation. So we're doing great contact tracing. We're finding 80% of mildly symptomatic or asymptomatic people, and then they're quarantining with 100% effectiveness, obviously not realistic, but kind of giving us an idea of just how effective contact tracing could be. And the answer is, in this framework, it could be incredibly effective. So in these EMS, in the blue scenario, we've lifted all these shelter-in-place, stay-at-home policies, and we've implemented this really effective contact tracing, and we're predicting that this contact tracing would be effective enough to, keep us on that great trajectory without staying at home in those non-Northeast areas. So we looked at this, and when we thought, well, actually, what is going on in that purple scenario where it seems things are looking pretty good, but we maybe are still seeing a second peak. So we looked at that at the EMS level, and this is what it looks like. We're kind of seeing that second peak is almost completely driven by one particular EMS, which was EMS2. And we were like, well, what is so special about EMS2 that this level of contact tracing, which I think is pretty great, is not effective enough there? And so we went back to look, and it turns out that of the areas that are modeled to reopen, EMS2 has the highest initial transmission rate. So it's got a situation where contact tracing has to do the most work to keep transmission down. And this level of modeled contact tracing, 80% of infections found, and then 70 to 100% effective quarantine, was simply not sufficient to contain that higher initial transmission rate. And I just need to note here that there is, of course, a lot of uncertainty in our fitted initial transmission rate, particularly for these EMS that have recorded fewer cases and fewer deaths, because there's not very strong data to inform what we expect COVID spread to look like in the absence of intervention. So just because this particular instance of our model is saying, oh, in EMS2, we think there's higher initial transmission, that may not actually be true because of the limitations of the data. And so I do want to reiterate that I would really not refer to the results of our model as data. Even if I'm outputting a bunch of numbers, those numbers are not data, they are models. And we can only be as good as the data that goes into informing our models, only as complete as that data can be. We can plug holes with assumptions, but sometimes assumptions are reasonable and good assumptions, and sometimes assumptions are flawed, and sometimes they're flawed but still the best that we can make. So it's a process to continually improve models, to start to account for things that we learn are important that we haven't accounted for yet, for example, such as the underreporting of the deaths. But as more data comes in, we will be continually comparing our models with the data. The suggestion that stay-at-home has kind of is not being as well complied with now as it was previously. We want to be looking in the data to see if we see that as a true signal, and if so, we need to modify our models to then better understand just how much of an uphill fight our contact tracing needs to battle. So where do we go from here? There's a couple of model improvements that we're currently working on. One is to put in age structure into our model. So that means we'll take that entire big model and then replicate it multiple times, where each time represents an age group, and the age groups contact within each other more, and then between each other a little bit less. And something like this lets us do things like what is the impact of school closure specifically, where you can tweak just the contact rate of school-age kids. What is the impact of working from home? You're tweaking just the contact rate of the working age population, et cetera. So that will allow us to do a lot kind of finer understanding of these different types of social distancing interventions. It'll also allow us to model, age-dependent disease progression. We know that older people are more likely to have more severe COVID and to have higher COVID mortality. So that's something that we can put into the model once we have this age structure. And kind of like the grand vision of how complicated could this get is that we can model for each EMS the full age structured model, and then also model human movement between EMS. And the human movement right now, I think, is a little bit less important, but as hopefully we reach far lower levels of COVID, then the fact that some EMS have higher prevalence and some EMS have lower prevalence, and the issue of importation rate becomes a lot more important, and that might be something that we want to capture, especially if we're asking questions about heterogeneous COVID strategy across the state. So then to kind of finish up before we leave room for questions, I just wanted to have some kind of broad comments about reopening from my perspective as a modeler. So the first thing and the most important thing, I think, is that given that we are reopening, that we want to know as soon as possible if things are starting to get worse in places that have reopened or even places that haven't reopened, so that we have as much lead time as possible to decide what we want to do. So that means that if we're looking at an indicator like death, that's probably too downstream. We want to be looking at far more upstream indicators, and that means not just hospitalizations, but also prevalence. And if we want to be looking at things like prevalence, we need testing, so much testing, and there's some requirements around testing that our group will be looking at. So how fast do turnaround times have to be? Just how many tests per day do we think we would need under various strategies? Like I talked about some contact tracing scenarios here, but what I didn't mention is just how many tests that you would need to be doing in order to do this contact tracing effectively. So as I mentioned, if we want to assess prevalence, so the fraction of people who are infected, that means that we're also thinking not just about symptomatic people, perhaps, but also about asymptomatic and pre-symptomatic people to try to catch the infections as early as possible. And some kind of sentinel surveillance might be a really kind of reasonable way to assess that with pretty good spatial granularity, and then as fast as possible. This could mean things like testing all symptomatic outpatients, whether when they have COVID-like symptoms, just give the first 20 that you see at the clinic a test and see how many have COVID. It could mean something like testing women as they come in for labor and delivery, because that's kind of a broad cross-section of the population. Of course, it's limited by age and sex, but it is kind of, lots of different women need to give birth, and that might be a good way to contact people to assess prevalence. So I also talked about contact tracing in this talk. We are preliminarily predicting that contact tracing needs to be pretty good and quarantine has to be pretty effective. What does it, can I put better numbers on the words pretty good and pretty effective? That's something we're working toward. But even if I say that, pretty good means 80%, that doesn't really tell anyone like how exactly do we achieve 80%. So there's a huge piece of implementation and operational understanding that needs to happen in order for us to like really understand what it means to do high quality contact tracing in quarantine. So relatedly, we want to have the support structures in place from a public health perspective that let people get tested quickly. So if they need to get a test, then they can take time off work to go get that test. The test is accessible. They don't have to travel very far, take a lot of time to go do it. And if people are asked to quarantine, that they can quarantine, they can quarantine safely, they have food, they have what they need, they have medications if they need medications, so that we can increase the compliance with quarantine, because we've seen that that's very powerful. IDPH is also very concerned about vulnerable populations. We know that there's some really bad outbreaks in long-term care facilities. other populations, prisons, the meat processing workers, potentially agricultural workers as the agricultural season comes and goes, and other essential workers. These populations might be populations that we might want to kind of monitor more closely because they can be so vulnerable, and we want to make sure that they're protected as much as possible. And then lastly, I just want to underline again that different areas of the state may very well require different strategies in order to contain COVID. I would expect that up here in Chicago, we might need to have the most intensive strategies because we're a denser area with kind of a higher baseline contact level. And then people who live kind of more separated, who tend to drive to work, who don't contact as many people or as many vulnerable people, they might be able to go back to a much more normal life sooner. But this is all still, very much in flux. IDPH is thinking about this, the governor is thinking about this, like we are thinking about this. So hopefully in the next few weeks or months or however long it takes, we can start to get a kind of rigorous framework for thinking about how to reopen and what indicators and thresholds are good ones to be following. All right, so that kind of wraps up here. I want to thank all the people who have been working with me on this. It really has been a huge group effort. So I'm showing here basically everyone who's had a part, large or small, in putting together the work that we've done here. The purple names are people from Northwestern, and we can see that we are proudly the largest group, but also there's been so many people from outside Northwestern who have contributed. I want to highlight particularly Manuela Runge, who's my postdoc, who has led the COVID epidemiological modeling effort. She's truly been heroic on this project. Reese Richardson and Patrick Clay have also helped a ton with the calibration of the model and with various data analysis pieces. I want to acknowledge our research computing staff and Quest, our HPC, for giving us free resources for running, lots and lots of simulations. And actually, we've had really good luck reaching out to corporations and saying, like, we're working on COVID modeling, can you give us stuff for free? So that's been just really generous of them. And then lastly, I want to thank Sarah Kobe from the University of Chicago. She's another modeler who's working on these Illinois problems. We're part of a modeling group along with UIUC and Argonne that was organized by the governor's office to inform these kinds of questions that I've talked about today. So with that, thank you so much, and I'm happy to take questions.
Thank you so much. I've been cataloging the questions. We've had quite a few, so I will present them as they came in. We have a question from Reno Stevens. He says, what actually is the latency period for COVID versus the incubation period, which is on average 5 days or so?
What does he mean by latency period?
Okay, so Reno, if you want to message me again and just clarify, I can clarify, but I'll move on to the next question. So thank you for this is from Ron Willis. Thank you for a great presentation. Is the IDPH using the same model? Many people are using agent-based models, which tend to be more accurate, subject, of course, to good data.
So the question is IDPH using the same model?
Yeah.
As far as I know, the modeling that goes to inform IDPH and the governor's office are the 4 academic groups that they have assembled. So that there's us with the compartmental model, U Chicago and UIUC are also compartmental models. Argonne has an agent-based model. Their model is focusing on Cook County or Chicago, I forget which one right now. So they are not focusing on downstate regions just yet. The claim that agent-based models are more accurate than compartmental models is an interesting one. In my malaria life, I exclusively use agent-based models, so they are near and dear to my heart. For me, it doesn't make total sense to make that claim because it's not just the data. but also how you've chosen to structure your model and parameterize your model that make it more or less accurate. And at the end of the day, we want to have an appropriate model that addresses the questions that we want to and need to address. And sometimes an agent-based model is more appropriate, and sometimes a compartmental model is totally fine. So, you know, you got to pick the tool that fits the question and other needs you have, like around timelines or things like that.
So I got a little bit of clarification on Reno's question. He was referring to time to being infectious. So when he asks, what is actually the latency period? He means time to being infectious for COVID versus the incubation period, which is on average 5 days or so.
I see. So, so what he would call I would call that incubation period and maybe pre-symptomatic period. So we include both of them. We have both a few days that you spend in the exposed state and non-infectious, and then you also have a time in the pre-symptomatic stage where you are infectious, but you're asymptomatic. So I think probably both of them together are the incubation period. I hope I'm not wrong on this because we don't really think about this too much for malaria. And then the latent period is probably just that time spent in the E state, but altogether it's about 5 days.
Okay. So this is from Lee Lindquist. Age 64 and older is very broad, considering that age 80 plus is most affected. Would you ever consider parsing out the old from the older old?
Sure. I mean, the age model that we're currently building has age groups and not 4. I was using a bit of an older slide for illustration. So we are doing every decade, and then yeah, 80 plus. So that is in there.
Okay. Sorry, I'm getting a little lost here. Okay, from Catalina. Can models take into consideration communities in which quarantine is more difficult? For example, low-income communities in which families tend to have more people and a smaller area to live, which prevents isolation.
Yeah, the models can definitely take that into account. I mean, when I model quarantine, I just put in a number that represents what % of your infectiousness has been kind of removed. And, you know, perfect quarantine would be 100% of your infectiousness. But if you are unable to do that, then you might only be, you know, cutting down 50% of your infectiousness or 80%. And the challenge is how do you translate from a real life situation, which is, you know, families living together, into a number which is like you've removed 70% of your infectiousness. That is difficult. And that is a place where agent-based models would be particularly useful, actually. So I think there are people who are kind of using agent-based models to try to get at those effect sizes, and then once they have some estimates of effect sizes, then like we people who use compartmental models who are modeling at a larger spatial scale can then plug those in.
So a question from Lee Lindquist. There's actually 2. So when are you going to model long-term care facilities or nursing homes and COVID? These are easily the hotbed of COVID-19 right now. That's the first question.
Well, I would turn the question back to you. What is the question that you want modeling to answer by developing a model of those areas?
Okay, I'll let her respond. So when you discuss reopening of Illinois, how does the reopening reflect reopening or loosening restrictions on visitors to nursing homes?
I think you would have to look in the governor's plan for that, what exactly they are lifting restrictions of on each stage. I think they have 5 stages of reopening, and each one has some specific things that are now allowed and some things that are still not allowed. So I would just look in the Project Restore documentation for what he is and his team are envisioning for that. What we would want to do in our models, we would want to kind of look at the data to see what the impact of transmission has been of each reopening stage, and kind of be able to capture that at a large level.
I got a little more clarification from Lee. So she says, modeling interventions to reduce COVID entry and spread in nursing homes would potentially save lives of older adults who are most vulnerable and experiencing the highest rates of mortality. Have you given any priority or thought on modeling this? Oh, I guess, sorry. I think maybe she already asked that question. I'm getting a little lost in all this.
Yeah, so I mean, we are looking at nursing home stuff. Like, we're starting to look at the county level, which areas seem particularly vulnerable to outbreaks in long-term care facilities. The question of what would be most effective in a long-term care facility versus in the population at large, I am still thinking about that, to be honest, but it seems like the same kinds of principles we would apply to kind of the general populations, we would want to, at the very least, apply those in the long-term care facilities, right? So for every symptomatic case gets a test. Every contact of a symptomatic case gets a test, and those tests happen very quickly, and the turnaround time is fast. And if you are positive, then you go into isolation. So that all needs to happen. Special considerations around the long-term care facilities, I think I would consider things like not just testing of symptomatic people, but also regular testing of residents and staff, just in case someone is asymptomatic or pre-symptomatic. You want to catch that as soon as possible so that they can be isolated and then they don't come in and contact the vulnerable populations. So the extent to which that would be successful, I think, is unknown. I mean, I know that if I put that into my model, I can probably describe things like, you know, what fraction of people, of asymptomatic or pre-symptomatic people coming into the long-term care facility you would want to be able to catch. But I imagine that would be very high. And from an implementation standpoint, you would definitely want to be catching all of them, right? Because this is a situation where one infected person could lead to a really devastating outbreak. So I don't think that there really is necessarily a policy decision from modeling beyond like a result that would say, yes, definitely do like testing every 3 days or something like that.
So we had a lot more questions come in, and Jaline, I can share those with you and the names of the people if you want to take a look at them. But I definitely want to be cognizant of everybody's time and thank everybody for coming, and thank Jaline so much for presenting her research and findings. I know everybody's really interested in, you know, figuring out the whole COVID-19 thing and figuring out how to do everything safely. So I know that her research is contributing to that. And I will be sending out a recording of the presentation for everybody who wants it and has, if you have any further questions, you can email IPHAM@northwestern.edu. Thank you, everybody.
Thank you, Zala.